meeting is now being recorded.
Okay, so let me start again. I'm Karen Carpenter from MiCCSI, and today we have with us Dr. Kelly Armstrong from Mary Free-Bed Hospital. She is a full-time physiatrist there, and Dr. Armstrong specializes in treating patients with complex medical illnesses, cancer and related conditions, musculoskeletal injuries, women's health, and sports-related injuries. Dr. Armstrong is a graduate of Michigan State University, College of Human Medicine. She completed her physical medicine and rehabilitation residency at Mayo School of Graduate Medical Education in Rochester, Minnesota. We also today have another speaker who's going to join us, and he's going to introduce himself.
So my name is James Hartlein. I'm the Director of Spine and the Pain Center at Mary Free-Bed Hospital. I've been a licensed PT specializing in spine for 24 years, and I have the honor to work in an interdisciplinary model with Dr. Armstrong on a regular basis.
All right, welcome everybody. My name is Kelly Armstrong, and we're going to get started. So you'll see me flipping the slides. I have them in front of me, and you'll see me flipping them on the screen in front of you. So we're going to talk about the strategy that will fix spine care today. Now that's kind of a nebulous thing, so we're going to get into a little bit more detail about what that means. So let's get started. So a couple of things about Mary Free-Bed as a company. This is our 125th birthday year. So we're celebrating that. We're the 5th largest rehab hospital in the United States, so growing all the time. That might change actually in the upcoming years, so look for that. We do have a big mission, but we fit that into our logo, which is at the bottom there. That's restoring hope and freedom through rehab. And so that's kind of in a nutshell what we attempt to do with all of the patients we see, both in the inpatient and outpatient setting. So today's objective, just a few of them in front of you. So a quick history about what we do in the Mary Free-Bed Spine Center. We'll both talk about that. We'll talk a little bit about the epidemiology about low back pain in the U.S. and what that means as far as conservative and surgical treatment management strategies. We'll discuss kind of solutions that are looked at by this specialty kind of spine center, which we call interdisciplinary. That means that there's multiple types of people involved in the treatment of these patients. We'll talk about typical treatment plans that we have for people. We do focus on the conservative side of things, and so escalation of that treatment is based on patient symptoms, but we really try to avoid surgery. And then talk to you guys a little bit about how to give patients realistic expectations about what they're going to be dealing with when they have a back or spine-related issue.
So a little bit about the interdisciplinary spine and pain center models that Dr. Armstrong referenced. This is a data-driven model providing comprehensive care for spine-related patient problems. The interdisciplinary model is a collaborative evaluation that we developed approximately 3 years ago. And in essence, and we'll talk a little bit further about this, it's an evaluation that involves both the physiatrist performing their musculoskeletal and comprehensive history, and then we combine that with a physical therapy evaluation mechanically, and then that feedback is given directly back to the physician as well as to the patient, so that we're moving through the process as efficiently as possible, generally in the same visit. So the Agency for Healthcare Research and Quality has summarized the interdisciplinary spine and pain center into 4 major components. The medical care is provided by our physiatrists who all specialize in spine care, among other medical algorithms. Physical reconditioning, the research in the last 5 or 10 years really looks a lot at the importance of getting these folks moving from an exercise standpoint, and more importantly, educating them about the process of movement, how that affects their back pain and their recovery. Behavioral medicine has become huge in the last several years in regards to helping employees and patients deal with the effects of being off work or having an injury that interrupts their activities of daily living or function. And we have obviously a pain center that has highly skilled pain psychologists who then work with our PTs and OTs that all specialize in the care of pain when the spine pain goes from acute to subacute to chronic and or disabling. And then the last one is patient education. And this is huge from our perspective in regards to the fact that our philosophy is to empower the patient to treat themselves, and therefore that allows them to be able to prevent recurrence more optimally. It's a vital step in therapy and in spine care across the board. because we've learned over the last 20 years that therapy cannot be passive for the patient. They have to be involved in making the changes to allow them to not only get better, but to stay better.
So we're going to talk about some team roles next, and in our spine center we do work as a team. So as Jim was sort of going over before, we have a physiatrist, that would be myself or one of my other partners, looking at the patient first to really sort of evaluate the cause of their pain and any anatomic reasons for a patient to have back pain. That in itself will guide our decision to whether or not a patient needs additional imaging. Now that might be just as simple as an x-ray, it could be as far as an MRI or a CAT scan, or even a nuclear medicine study to look for areas of inflammation. Now not every patient needs additional imaging, so we'll go into that a little bit later on in the slides, but just know that that's not kind of an absolute as far as a patient treatment strategy. The physiatrist also looks for utility of medications for management of pain. We'll go into this a little bit more as well. We really try to minimize medications, as we haven't seen in the research that they actually affect people in a positive way in the long term. We look at utility of less conservative options for treatment, and that looks like injections or surgery. We do have injection therapy out of our office. That works for more acute management of back pain. Like I said, surgery is avoided if we can, so that's not something that we're doing very routinely as far as referrals to surgeons, but it is a possibility. The utility of physical therapy intervention is assessed as well. Generally, we're doing that as a team-based visit, so a physician will see the patient first, followed by a therapist in the same visit, so that we can talk about the patient in front of them and sort of explain with medical terms and non-medical terms about what their back pain means and what likely treatment it will respond to. And then as sort of stewards of medicine, we look to decrease the cost of the treatment plan and do more of a stepwise approach to treatment. So rather than seeing a patient first off and saying, well, it looks like you need an MRI study and an injection and this medicine and maybe a surgical evaluation, we do it more thoughtfully than that. So we start at the baseline and say, well, maybe we should do some limited imaging, so maybe an x-ray or maybe just therapy intervention, and sort of see how each thing affects the patient one by one rather than throwing the book at them.
So on the therapist side, the responsibility that we bear is to make sure that we do a very thorough mechanical spine evaluation. We utilize the McKenzie process for this because it allows us to focus significantly on the patient's history and involve them immediately in the care plan. It also, more importantly, allows us to determine whether or not therapy, if you skip down to number 3, is the most appropriate tool. There are times when the patient is not appropriate, and we average somewhere in the nature of, I believe the last study showed 4.8 visits of spine therapy per case, because we are determining either that they are better, they will get better, or that we need to reconvene with the physician to determine a more appropriate pathway. The communication with the physiatrist is immediate, and as Dr. Armstrong pointed out, it is in front of the patient and with the patient, determining the plan so that we can move forward with everybody on the same page. And then last but not least, our job is to make recommendations to the entire treatment team to facilitate optimal functional restoration. That may be that the patient does not need formal physical therapy, but they might be ready for occupational therapy, for work hardening, for work reentry, for simple ergonomic assessment, and to get them back to full functional activities.
So here we have a few research studies that talk about how the outcomes are affected by using a team-based approach. So using an interdisciplinary model involving the use of a therapist, a physician, potentially psychology as well, that actually is shown to decrease prescription medication use by about 63%. That's a huge decrease. So like I said before, using medications isn't always the right thing to do for a patient with pain. A lot of the time pain is mediated by many other things besides anatomy. So doing an interdisciplinary approach actually minimizes that risk of having unnecessary medications. The interdisciplinary approach is also shown to be more cost-effective than just going straight to surgery. So a surgery for just a simple lumbar laminectomy, just a one level that might be a microdiscectomy, which generally takes a one-night hospital stay, may cost upwards of $30,000. Doing an interdisciplinary approach to avoid having that procedure done, both by therapy and support from a physician for sort of expectations on what it looks like for a herniated disc to resolve, costs far less than $30,000 to have a number of therapy treatments and physician consultations. So that research study is pretty apparent as far as cost reduction. Patients are it's 12 times more cost effective than conventional care for trained patients to work. So rather than messing around and dealing with having patients off of work for prolonged periods of time, having the support of a team to help return them to work actually shows that they get back to work sooner and require less visits. And in that same line, there's a large reduction, a 50% reduction in disability. So these patients are less often applying for Social Security or long-term disability because of a team-based approach. So in that, the clinical practice guidelines have sort of reflected that recommendation that a team-based approach really does help much more than anything else, anybody independently, in reducing patient risk. So this is just an article that sort of reflects that. This article actually in itself highlights the utility of having a physiatrist or a specialist in physical medicine and rehabilitation like myself see a patient prior to going to a surgical consultation. We all know that going to a surgeon doesn't necessarily mean that you're going to have surgery, but it is much more likely when a patient visits with a surgeon that they will have surgery. Having a physiatrist in the middle of that actually helps with some of the deference of surgical care. So I see many patients that think that they need surgery but really don't, and so using a physiatrist for that role to help avoid the cost of surgery as well as the unnecessary risk of surgery is actually very helpful. So this study in itself showed a 48% decrease in surgical referrals. There are many patients that I do not refer to surgery because it's not helpful, and a higher satisfaction with their physical medicine doctor because they essentially saved a patient from having a surgery that was not necessary. So why did we do this interdisciplinary approach? This is sort of backtracking, but why is this something that even came to be in the first place? It's not like people sit around and say, I need to see multiple different people to deal with my back pain, but for some reason we did do it. So this is more of the epidemiology side of things. Low back pain is the most common type of pain, so it's one of the highest, you guys probably know this, but one of the highest reasons that somebody who seeks primary care evaluation is because of musculoskeletal pain, primarily low back pain. Most people in their lifetime experience low back pain for some reason, so that doesn't say what type of low back pain that might be, but many people have it. And there's a 20 to 30% point prevalence in the general population, which means that at any given time, 20 to 30% of people have low back pain. So it's a huge problem. And how big is that problem? So fifth most common reason for physician visits in the U.S., that could be specialist or primary care. Second most common reason for primary care itself, and it's one of the costliest chronic conditions in the U.S. because it just takes so many resources to help patients deal with it. So we like to highlight that severity of that problem. And so, go ahead.
So only 20% of the cases have a known cause, and often as human beings we look for that cause because we really don't want to create that pain pattern. So finding the quick fix and avoidance of that known cause is the primary focus. Only 25 to 39% of Americans ever are treated for low back pain, and really the studies show that 80% of symptoms with low back pain in the acute state get better in the first 8 to 12 weeks, regardless of the intervention. 60% of those treated continue to have pain a year later, and per a research article that came out several years ago, upwards of 75% of patients that have a flare have a larger flare in the next year if we don't educate them to avoid what caused that flare in the first place.
So this is just a slide that sort of highlights the top 10 causes of disability. So we're very interested in this because this is one of the biggest financial burdens on society at this point is disability. And so you can see that back or spine problems is the second. And so that's a huge issue that we need to sort of address from this team-based approach to help bring that down or help to avoid people to go on to actual disability because of it. Kind of going along the same lines as far as work-related disability, it's the second most common reason to miss work. A vast majority of workers' comp costs is because of back pain, and 14% of the general population miss work each year because of low back pain, so that's also pretty striking. So what's our preference? So this is population-based preference. So that means in the general population, if you were to ask people who have low back pain what they want to do about it, most people are going to say certain things. And so to highlight that, the U.S. has one of the highest rates of lumbar back surgery in the world. And so that's pretty important to know, in that what we're telling you is that not all patients that have back pain need back surgery, but we still continue to do surgeries on a lot of different people. This is higher than other countries. It's been going up and up and up in the last decade, so it's sort of a population-based problem at this point. This is a slide that highlights how many people have back surgery kind of across the country. So it's looking state-by-state comparison of the Medicare population, and the darker red you are, the more back surgeries happen in your county. And so if we look at our home state of Michigan, we're not doing very well. So we're having a lot of back surgeries in Michigan, a lot throughout sort of the upper West Coast, and the reasons for that are difficult to kind of ascertain from a slide like this, but just know that Michigan is a very high rate of back surgery state. This highlights Michigan specifically and sort of the rest of the Midwest. It's just very interesting to look at this to see that the majority of Michigan is worse off than our neighbor states. And so it doesn't even necessarily relate to the higher population areas in Michigan. The Detroit area doesn't really have necessarily a higher than anything else. The low population areas, or the UP and the upper lower peninsula, are also very high. So we need to figure out how to bring this down to help with cost reduction and to help patients avoid surgeries that aren't necessary. This slide highlights the inpatient back surgery per 1,000 Medicare enrollees, but the gender part isn't really important on this slide. Essentially what this shows is the same thing I just told you, that Michigan is really doing worse off than the rest of the surrounding states. So it's sort of a culture-based thing within our home state that people are typically getting back surgeries that wouldn't necessarily happen in another state.
So when we opened the Mary Freebed Spine Center 3 years ago, a little over 3 years ago, the average surgical rate for the patients that came to the clinic was just over 12%. The recent data that was just run has shown that that percentage has now dropped to 5.6% of our patients that actually get to a surgeon.
So this is another preference-based slide. So we just talked about surgery. Now we're going to talk about medications. So our preference is when we go in, not necessarily all of us, but when a lot of people go into the primary care doctor or a specialist doctor related to back pain, many people think that they're going to walk out with a narcotic pain medication prescription. This is an epidemic problem within our population. The CDC recently released a statement about the epidemic of opioid prescribing and narcotic addiction in the country. And as physicians in this area of care, we're contributing to it. So Americans constitute a large supply of the global supply of opiates, about 80%. That's a really interesting statistic. 80% of the world's narcotic supply is consumed by U.S. population. And for hydrocodone specifically itself, so that's your Vicodin medication. Vicodin is hydrocodone plus acetaminophen, or straight hydrocodone. 99% of that is by Americans. And that's kind of an interesting thing to think about, too. It's not that patients are necessarily coming in and requesting hydrocodone specifically, but it's become a doctor preference to prescribe it. So that's just something that's interesting to know about. A little bit more on that same topic. 40% of opioid prescriptions are written by primary care doctors. So patients don't even necessarily need to get to a specialist before they encounter that medication. That hydrocodone has increased by 280%, the prescriptions for that. And then methadone, one of what I would consider the last line treatments for chronic pain management, and not even necessarily an appropriate treatment for chronic pain management, has increased by over 1,000%. So that's also indicative of that same opioid crisis. And so this is another state-by-state analysis of how we're doing as far as that opioid prescribing, and you guys can see there that Michigan is also not doing well with the opioid epidemic. So in our home state, we're prescribing more narcotic pain medications than a lot of other states in the country, so just further contributing to that same problem. And now what's our preference about what to do about back pain? So we've talked about surgical techniques, we've talked about medication prescribing. Now, to backtrack just a little bit, what to do to evaluate it. So many patients will come to my office and say, I need an MRI study before I even touch them, before I even really talk to them about their story. And so that in itself is a patient education issue. So we do have evidence that shows that looking at the back with an MRI or a higher level study does not necessarily improve patient outcomes, could expose them to unnecessary harm. That would maybe be in the case of using a CAT scan or something that exposes the patient to radiation, and definitely increase cost. So the average cost of a lumbar MRI is somewhere between $3,000 and $6,000, depending on where you have it done. If that's not a necessary test, that's also not necessary money. Patients from high imaging use areas are 5 times more likely to have an MRI or a CT scan without a clinical outcome. So just because we have an MRI study doesn't necessarily say that the patient is going to do any better. So that's something to keep in mind as well. And so this is an interesting just statement. Depression is a stronger predictor of who will report low back pain than baseline imaging findings. So that's just saying that if somebody has depression, that's actually more predictive of a low back pain diagnosis than somebody that has a positive finding on an MRI. So just because somebody has arthritis that we can see on their MRI or a disc bulge, that doesn't necessarily mean that it causes them pain, but depression and low back pain are actually linked stronger than that. So what's our preference with imaging? So the United States, out of everybody in the world that was assessed for this study, does far more MRIs than anybody else. And so that's really looking at sort of a physician culture and a patient culture preference that we like to see what we have going on, and we like to do something about concrete images, even if the images don't necessarily support the symptoms. That's kind of what I see daily in my office. So this slide is talking a little bit about procedures. So this is non-surgical procedures. So this would be like your epidural steroid injections, your joint injections with usually some sort of corticosteroid. And so it's saying that we really have increased at least facet joint injections, so that means back joint injections over the past 10 years, and this study is a little bit old. I would expect that that has increased even more since then. That has a lot to do with a few different things, and so the number of doctors doing those procedures has drastically increased, and the culture behind that is actually more related to the reimbursement for those types of conditions. So doing a injection or doing injections in your practice for the majority of your day does tend to make a lot of money for the doctor, so that has changed in the past 10, 20 years that more and more doctors are getting into that. The other thing is patients want things to be done, but not necessarily surgery. So patients will come in and say, I don't want to have surgery, but you have to do something. And so this is the something that can be done. The thing about that is there's not really much evidence that says that these injections are helpful. And so even though we're doing something, are we really doing something that causes the patient any good? What one study says is that joint injections with steroids are not really more effective than placebo, so that means they should put saline into the joint for pain relief or improvement in disability. So long-term outcomes of patients that do injections versus don't really aren't much different. So sort of the summary of what I've just talked about, lots and lots of people get spine pain. The treatment is really preference-driven in this population right now. So in the U.S., the patients kind of get what they ask for. Not really evidence-driven. So we're not practicing evidence-based medicine, which is really the wrong thing to do just because of the increase in cost and patient harm. But Americans do prefer surgery, imaging, pills, and injections. So do something for my pain, not just do therapy or do depression management or things that aren't necessarily tactile. And Michiganders personally have expensive preferences for treating spine pain. So that's really looking at the imaging, surgery, and injections. So what do we do about this? This is something that I've been in practice for a few years and sort of fight this on a daily basis, but what do we do? It doesn't seem like the right thing to do to refer every patient to surgery. It's not the right thing to get an MRI on every patient. It's not the right thing to do an injection on every patient. So how do you make patients come into your office and feel satisfied when you're not doing those things for them? And so this is a clinical practice guideline document about what the recommendations, at least from the American Pain Society, are about management of pain. And so you guys can look through the recommendations independently, but essentially what it says is the provider should be doing an excellent history and physical examination so that they can really use their clinical knowledge to help identify the source of pain rather than going straight to imaging. They should not routinely obtain imaging if it's not necessary. They should perform diagnostic imaging for patients that have severe or progressive neurologic change. So if a patient comes in and says, I have a foot drop that's getting worse and worse and worse, or I have pain that's preventing me from getting out of my house, so that would be called intractable pain, or if I have bowel and bladder dysfunction, those are things that really highlight in my brain about reasons to actually go for advanced imaging. If somebody has persistent low back pain or radicular symptoms, so that means leg pain, those things are more likely to get an MRI study and potentially have surgical management. And so just going through these recommendations, which tend to sway towards the conservative side of things rather than going straight to injections, imaging, and surgery, are really what's recommended, at least from these clinical practice guidelines. This is just a work-in slide about what we're currently doing at the spine center that I work at. And so there are 4 doctors now that work in this spine center. All of us have like-minded rules about what should be done for patients with typical conditions seen in spine care. And so typically I don't prescribe medications. And the other thing that's highlighted on this is that really only about 4 to 5% of patients that ever walk through our door will receive a narcotic medication. For myself, really the only reason that somebody would warrant having a narcotic prescription would be if they had acute onset radicular pain, so they had a herniated disc happen a week ago and were getting over sort of the acute phase of that in the first 1 to 2 weeks following the occurrence. If they had cancer-related pain, really those are kind of the only things besides fracture or something else that needed surgery that would warrant a narcotic prescription, at least for myself. And so the rest of the doctors in our practice are very like-minded in that. There are many other medications on that list. Most of them do not require a DEA number for prescription. And so we try to stay in that line if we're going to be prescribing medications, but typically patients don't have medications prescribed. This is looking also at our own spine center and what we typically do. And so one thing that Jim went over just briefly previously is that as far as surgical referrals go, that 12% has actually decreased to about 5% at this point. So most of our patients, 95% of our patients, are not going for surgical referrals. And the other thing that you can do to sort of understand if you're doing a good job with your surgical referrals or not are how many patients that you refer to a surgeon are actually getting surgery. And so I have not had a patient that has been declined surgery when referred. And so that just ties into the appropriateness of referrals and using physiatry as sort of that gatekeeper. The ESI referrals, that's epidural steroid referrals. Most of our patients are not getting epidural steroid injections. The ones that are typically do receive benefit, and we keep pain diaries for these patients so that we know if they improve from them or not. And then we don't typically repeat injections unless it was significantly helpful. We also have an algorithm to prevent repeated injections that are too close together to help with patient steroid exposure and overload to steroids during the course of a calendar year. So those things are in place to help protect patients from that assembly line sort of pain practice where patients come in, have their injections every 6 to 8 weeks, and really those things aren't monitored as closely. Our MRI referrals are also pretty low. We do MRI studies for things like I talked about before, so that would be progressive weakness. progressive or intractable pain, or bowel and bladder dysfunction. Those are sort of the 3 red flags that we typically will do them for. But otherwise, we tend to stay away, at least initially, to see how far we can get without needing to go down that road. What I always tell patients about MRIs is that we do MRIs to plan for something. So we don't do MRIs because we're not sure, because the history and physical exam will usually tell us what's going on. But the MRI will tell us what needs to be done about it sometimes. So if we're planning for something like a steroid injection, we need to see the anatomy to target the correct place. If we're thinking about surgery, then we're thinking about, well, what do we need to do specifically for surgery? An MRI is not typically done purely for diagnostic issues, but really to look at diagnostic and then treatment strategies based on it.
So where does work hardening and conditioning fit into our algorithm of care? In essence, when we see the patients in our interdisciplinary spine center, our first focus is to reduce the pain, because that's what's on their mind. The second focus is to empower them through our mechanical assessment and our evaluation process to keep the pain reduced while restoring function. Once we restore function, as I mentioned earlier, that happens in 4 to 5 visits. Then we look at prevention, because as we talked about earlier, most people with a back pain episode have a larger occurrence within the next 12 months, up to 75% of those patients. So that's when we integrate prevention strategies, usually using our ergonomic specialist in the occupational therapy clinic. Those work hardening components, and most of you are familiar with this, but they focus on aerobic conditioning because the literature brings out in a multitude of studies in the last 5 years that exercise primarily brings healing potential through blood flow and oxygen to the tissue that we're trying to fix. Strengthening to get them adequately conditioned to actually perform their job duties, and that includes things like lifting mechanics, body mechanics. Ergonomics are hugely important. If we have somebody with back pain that, as we know, a predisposing factor to low back pain is prolonged sitting, most people don't sit in a proper ergonomic setting, so that needs to be fixed. Patient education in regards to how to avoid and prevent recurrence, and then a thorough analysis of, okay, what do you actually do for a living, and how do we teach you to do it so that we can prevent a recurrence of this both at home and in the workplace. Some patients progress to needing a functional capacity assessment. This is a one-time 3-hour test. It's a thorough history done by the occupational therapist who is ergonomically trained to basically look at the positional and movement tolerances, both static and dynamic, for each individual patient. What can they and can they not do safely in regards to where their back condition is? It helps us to determine what their functional status is in relationship to life activities as well as their regular job duties. It determines at times functional status to begin vocational process after MMI, to help determine functional status, to allow those information to get back to the interdisciplinary model with the physiatrist in relationship to disability filings, and it also determines a baseline for where they are from a rehabilitation process.
So as far as expectations to give patients when they may come to see us in the Spine Center, I don't want people to think, oh, they're not going to do anything for me if I go to the Spine Center. So I just told you guys that we don't typically do imaging, we don't typically prescribe medication, we don't typically do surgical referrals. So what do we do? And so the expectation is that the patient comes in and somebody listens to them. So the physician spends the adequate amount of time with them, listening to what their complaints are, listening to how the pain affects their life, and then doing a good physical exam to kind of figure out where is this coming from. Is this something that's related to the spine itself as far as joints or nerves or things like that? Is it something that's related to the muscles overlying them, which is more likely the case, and not necessarily something that was caused by an accident or injury? And then working in a tag team approach with the therapist to adequately treat the patient physically prior to going forward with anything else that may need to be done in the future. And so that's sort of the cornerstone, the baseline of our medical management. Going up this pyramid is sort of the stepwise approach that we try to take to help patients the best that they can be helped. And so the next line is sort of, do they need medications or do they need imaging? Those things aren't necessarily exclusive of each other. but sort of follow along that same sort of next step. The next one was controlled administration of medication or injection therapy. Again, these are just things that are less likely to be offered for patients, less likely to be needed for patients, and then surgery is the last resort. Do you have anything else for that one?
No, I would say that the role of the therapist in that model, in addition to the mechanical evaluation, treatment, feedback to the physiatrist, is to also let them know when therapy is not the right tool. A lot of times in physical therapy, unfortunately, that process can take 4 to 6 weeks, and at that point, the patient has become more sedentary and less functional. So that helps the patients maintain function by moving through that algorithm at a quicker pace.
So the bottom line, the expectations are really that the patient is going to be experiencing the interdisciplinary model of care, and so that's having multiple people work on their case to help improve their function as best as possible. And prior to doing that, making sure that that's a safe thing to do based on what their anatomy is. We try to avoid unnecessary testing and procedures, and in that, reduce costs. So if a patient truly needs a test or procedure, then they truly need it, and we don't avoid it that way. So cost isn't sort of the first priority. Patient care is the first priority, but doing appropriate patient care for spine-related conditions really does reduce cost. We try to avoid addictive medications. We're trying to follow the CDC guidelines that were just put out about narcotic pain medications, and even prior to that being put out, we were following it very well. We do have access to work hardening and conditioning programs, as Jim talked about, so determining when the appropriate time to do that is and trying to get these patients back to work as soon as possible. We also have access to the pain center that Dr. Hudson talked about recently with you folks as well. And so determining if there's something physically that can be done about the pain as far as physical therapy, injection, surgery, things like that go, then great, then we're happy to help the patient in our own house. But if it's more than that, if it's a chronic pain condition that has led to sort of hypersensitivity and central sensitization, making the patient experience pain to a higher degree than maybe would be expected based on their anatomy, then the pain center is a good place for them to go as well to help with more of the psychology side of chronic pain management. So we do have that available as well. So the rest of the slides in this are a lengthy list of bibliography references. You guys can go through those on your own as desired or not. And so now we can open up to questions, and we'll turn the mute off so that we can hear you.
All guests have been unmuted.
All right, do we have any questions?
Yes, could you go over more of the conditioning and actual work that you do with them?
So are you talking about like work conditioning?
Yeah, work hardening and conditioning.
Yep. So in essence, that's we have occupational therapists that are specialists in ergonomic education and treatment, and that involves getting the patients back to their generalized fitness conditions, going thoroughly through their job description to make sure that they are physically fit enough to be able to do that job after injury, and then to help educate the patient in self-treatment that they can do when they're at work or at home to prevent recurrence. A lot of that is generation of blood flow and oxygen into those tissues, getting patients moving again, and then again, as I said earlier, empowering them to continue to stay in shape, to stay fit, to be able to do those job duties.
Thank you.
You're welcome.
Any other questions?
This is Shelley Smith. I have a question. How do people get referred to you before getting referred to a surgeon?
Typically, I see my referrals coming through primary care doctors. It really depends on insurance as far as whether they need a referral or not. Some insurance companies are not requiring referrals to specialists at this point, but most of the time I'm seeing primary care doctors see the patients first, and then the referral to me comes through. One easy way to check that would be to call our office directly and have our front office staff just check that for you, just to see what's covered as far as specialist referrals or not.
Okay.
Some people just can come straight through the door.
And so more insurance are covering that?
Say that one more time.
You are saying that there is better coverage now for them to come right to you as opposed to having to go to
for primary care. Yeah, so I am seeing, it's not very often, but I am seeing some patients that don't require referrals. I think Priority Health is one of the ones that's doing that at this point. That's sort of the one that sticks out in my head that I'm seeing.
Good.
Any other questions? Well, it sounds like there are no more questions. First off, I'd like to thank both of our speakers. We really appreciate that you came, and it was an excellent presentation. I'm a nurse, so I can appreciate that. So I thank you, and I thank all the attendants. There are a few household things I need to do before you all hang up, though. I want to remind you to do your evaluations, and after you do them, you can fax them to us, or you can email them. Does anyone need our fax number? Because I can give it to you. And I also want to let you know you'll get your 1 CE. Well, after we receive your evaluation, it takes up to about 2 weeks after that for us to get them out to you. I also want to remind you that we have another series coming up of webinars about asthma and COPD, and they start Friday, September 23rd. I think that's about it. Does anyone have a question about the housekeeping thing? Oh, okay. Somebody said they do need the fax number. Let me give that to you. It's 616-608-4058. You can email it to me, Karen Carpenter, and that's karen.carpenter@MiCCSI.org, and that's MiCCSI.org. So you can do it either way. And if you have any questions, feel free to call the office. Anything else? I think that's about it, and we can conclude this webinar. Thank you all.